I'll be taking practice question 1. The question reads, a 35-year-old woman with 3 clots of protein in urine, urea of 24 millimoles per liter, creatinine 268 micromoles per liter, not a non-diabetic, no hypertensive, has positive history of NSAID use for recurrent joint pains for 4 months, has pedal edema. She has a normal renal sizes on ultrasound scan. So A, mention 3 differential diagnoses. What is the most important investigation? Report of her renal biopsy was given and shown to you. What is your final diagnosis? Which 4 investigations will you do? How will you manage her? And what is the latest drug combination for antiretroviral treatment? So joint pain. So my first differential will be tubulointerstitial nephritis, most likely NSAID-induced tubulonephritis. So if I have the opportunity of seeing the other questions that follow, I will also include HIV-induced tubulointerstitial nephritis because of the last question that was asked. What is the best antiretroviral treatment of choice? So other differentials will include nephrotic syndrome because she has nephrotic range proteinuria, and then absence of hypertension. The use of NSAID will also be implicated in some forms of nephrotic syndromes, like the minimal change disease and the membranous glomerulopathy. So my third differential is analgesic nephropathy because of the chronic NSAID use. So lupus nephritis is also a differential because she's a female of childbearing age with features of renal impairment and chronic joint pain. So lupus nephritis is also a differential here. Then HIV-associated nephropathy will also be a differential. Other differentials, other causes of tubulointerstitial nephritis, left nephropathy, and other causes of renal impairment with normal sized kidney will be mentioned here, such as sickle cell nephropathy, and so on. So the next question, what's the most important investigation? So the most important investigation is renal biopsy and histology to help me in confirming the diagnosis. So question C, report of her renal biopsy was given as a histological picture of light microscopy with tubulointerstitial sclerosis, scarring, atrophy, and marked cystic dilatation of the tubules was shown to you. So what's your final diagnosis? So from the renal biopsy picture given, I have some slides here showing cystic dilatation with areas of tubular interstitial sclerosis, atrophy. So looking at the slide, the most likely diagnosis is tubulointerstitial nephritis, most likely NSAID-induced tubulointerstitial nephritis. Okay, so this is a better slide showing a marked dilatation of the tubules. You can see that the glomerulus is spared here, and in between the tubules, the space in between the tubules is the interstitium. So we can see some areas of interstitial sclerosis from this slide. So it's more in keeping with tubulointerstitial nephritis. So question D, list 4 other investigations you will do. So investigations include urine analysis and microscopy. So they've already mentioned in the question that the patient has nephrotic range proteinuria, which is seen in patients with NSAID-induced tubulointerstitial nephritis. Proteinuria is usually minimal or moderate it can even be absent in other forms of tubulointerstitial nephritis. So the patient can also have sterile pyuria, in which there will be presence of white blood cells, sterile pyuria, in which there will be pus cells, but absence of cultured organism. So the patient can also have microscopic or macroscopic hematuria. There could also be red blood cell cast or white blood cell cast. Eosinophiluria is typically absent in NSAID-induced tubular interstitial nephritis, unlike in other forms of tubulointerstitial nephritis. So they could also have hypostenuria or isostenuria. So still under urine analysis, I will be interested in urinary biomarkers, such as the beta-2 microglobulin, alpha-1 microglobulin, and monocyte chemotactic peptide 1. These are low molecular weight proteins that are normally endocytosed by the proximal tubules, but because the tubules are affected in this disease, so they are usually secreted and are excreted in the urine. So they are useful biomarkers to diagnose tubulointerstitial nephritis. So I'll also do some blood tests. EUC, she already has an elevation in urea creatinine. So because of the chronic use of NSAID, I expect to see hyponatremia and hyperkalemia. She could also have normal anion gap, features of hyperchloremic metabolic acidosis, hypophosphatemia, or hypouricemia. On CBC, she could have leukocytosis because she could have been taking antibiotics, or infection could also be a precipitant of tubulointerstitial disease. However, eosinophilia, which is typically seen in other forms of tubulointerstitial nephritis, will be absent in NSAID-induced tubulointerstitial nephritis. So I'll also screen the patients for HIV. I'll also screen for Hep B and C, because one of my differential is HIV-induced tubulointerstitial nephritis. And if it's positive, HIV can cause HIV-associated nephritis in addition to the tubulointerstitial nephritis. Hep B virus can also cause nephrotic syndrome, which is one of my differential. So I'll also do some other blood tests, such as serum antibodies, autoantibodies, and complements, so as to rule out lupus nephritis. Then other investigations, imaging tests like renal ultrasound scan, which they've already given us in the question. She has a normal sized kidney. The renal scan will also help in ruling out other causes of normal sized kidney, such as obstructive uropathy. So I could also go ahead to do CT scan, just to rule out other causes of obstructive uropathy. And in patients with analgesic nephropathy, there could be microcalcifications seen. They are more prominent. They are prominently seen on CT scan in the renal papillary tips in analgesic nephropathy. So the gold standard is renal biopsy, which they've already given me in the question. So renal biopsy will confirm the diagnosis. For patients with tubulointerstitial nephritis in the acute form, they usually have intense inflammation with infiltration of the tubules and interstitium by polymorphonuclear leukocytes and lymphocytes. So often there could be eosinophilic cellular infiltration of the renal parenchyma, typically sparing the glomeruli. So in the chronic form, which I expect this patient has, we can see scarring of the tubulointerstitium with sclerosis, atrophy, and marked cystic dilatation of the renal tubules. So the option E, how will you manage her? So management of this patients will entail a quick history, examination, investigation, and treatment. So from the history, I would like to find out, they've already given me history of NSAID
Please, you have 1 more minute.
Okay. So I would like to find out why she's taking the NSAID for the joint pain. Is there associated skin rashes, photosensitivity, alopecia? I'd also like to find out other history of antibiotic use, and so on. So examination, typically such patients, interstitial nephritis, we have the classic triad of fever, skin rash, and eosinophilia. So I would like to see if I could pick peripheral stigmata of other underlying disease condition that could predispose her to having this interstitial nephritis. Then investigations, I've already mentioned the investigations I'll do. So treatments entails removal of the offending agent. In this case, NSAID, I would stop her NSAID and if necessary, replace it with other analgesics like paracetamol or dihydrocodeine. So after removing the offending agents, I would observe the patient for 3 to 7 days. If the kidney function has not stabilized within this interval, the renal biopsy will be an indication. So after confirming the diagnosis of tubular interstitial nephritis, I would like to initiate glucocorticoid therapy. So for the dose of glucocorticoids, usually IV methylprednisolone 500 to 1000 milligram daily is used for the first 3 days, which is followed by oral prednisolone at 1 milligram per kg daily for the definitive management of tubular interstitial nephritis. However, some authorities question the role of glucocorticoids in NSAID-induced tubular interstitial nephritis. So I expect the renal function to recover within the first 2 weeks after initiation of glucocorticoids. So for patients that show an improvement in renal function, I would taper the steroid dose at a weekly interval. And then the total duration of treatment it ranges from 4 to 12 weeks. In patients in which there is no response to steroid, I will use immunosuppressive drugs like mycophenolate mofetil, usually given orally 1 to 2 grams per day. So option F, what is the latest drug combination for antiretroviral treatment? I don't know how this option came into the question. Probably the latest immunosuppressant was the question. Maybe there is a recall failure. So if it's immunosuppressants, I will use mycophenolate mofetil. However, if it's talking about antiretroviral treatment, then the drug of choice will be DTL, which is dolutegravir, tenofovir, and lamivudine. But in patients with nephropathy, would like to replace lamivudine with abacavir because of the nephrotoxic effects of lamivudine. And then, depending on the stage of nephropathy, if the eGFR is less than 30 mils per minute, the dose of abacavir will also be reduced to 50. The normal dose is 300. So I'd like to reduce it to 50 to 100 milligram. So I just put up a slide on NSAIDs and the kidney. So the various ways by which NSAID can cause kidney injury include by sodium and water retention. This occurs due to reduction in prostaglandin production, leading to increased renal sodium chloride reabsorption, and also decrease in sodium and increased serum potassium. So it can also cause acute tubular interstitial nephritis, which is a cellular-mediated hypersensitivity reaction. It can also cause membranous glomerulopathy leading to nephrotic syndrome. NSAID can also lead to papillary necrosis as seen in analgesic nephropathy. So it can also cause acute tubular necrosis and hyperkalemia by decreasing renin secretion, leading to angiotensin II induced aldosterone release. So such patients will have hyperkalemia and hyponatremia. So I don't think I'll have time to I just put up slide on tubulointerstitial nephritis because I'm not really sure if it's NSAID-induced tubulointerstitial nephritis or HIV-associated tubulointerstitial nephritis. So
can you pick some slides and summarize in 1 minute?
Okay.
Please. Okay, your time is already up.
So the most common causes of tubulointerstitial nephritis is drug-induced. So most often NSAIDs, antibiotics, infections are also causes, usually bacterial infections, viruses like HIV, then systemic diseases like SLE, Sjogren syndrome, and then it could be idiopathic. So the pathophysiology, the principal mechanism in acute tubulointerstitial nephritis is a hypersensitivity reaction. It can also cause acute cellular injury. So tubulointerstitial nephritis involves the immune-mediated infiltration of the kidney interstitium by inflammatory cells. Lethal or sublethal injury to kidney cells lead to expression of new local antigens, inflammatory cell infiltration, and activation of pro-inflammatory and chemoattractant cytokines. So these cytokines are produced by inflammatory cells and also by the kidney cells. So in acute tubulointerstitial nephritis, tubular damage leads to renal tubular dysfunction. And regardless of the severity of the damage, kidney dysfunction is usually reversible in the acute form. Chronic tubulointerstitial nephritis is characterized by interstitial scarring, fibrosis, tubular atrophy, resulting in progressive CKD. So serum components can lead to injury down tubular portions of the kidney, and then this can lead to secretion of inflammatory cytokines and extracellular remodeling, which may promote kidney fibrosis. So this is just a slide showing the pathophysiologic mechanisms of acute tubulointerstitial nephritis. It causes edema due to increased vascular permeability. It also leads to interstitial inflammation as a result of increased recruitment of anti-genetically activated cells, and also lead to fibrosis due to increased fibroblasts and matrix deposition. All of this will lead to tubular dysfunction, capillary dysfunction, and interstitial damage. So the other causes of tubulointerstitial nephritis, we'll go through them in the slides. So another important entity is tubulointerstitial nephritis and uveitis syndrome, which is a rare disease associated with the Epstein-Barr virus and other bacteria like Leptospira, Mycoplasma, and Yersinia. So renal failure from tubulointerstitial nephritis is usually the first presentation, and this is followed by bilateral uveitis, photophobia, eye pain, redness, and other ocular symptoms. Okay, so the classic...
We'll go through the rest of the slides when you post it.
Okay. So the investigations, I've already mentioned most of them in the questions. And then the treatment is removal of the offending agent, treatment of the underlying cause, depending on the cause. The mainstay of treatment is steroid. In non-response to steroid, you can use the immunosuppressive agents, MMF. So monitoring therapy is also important. This is an algorithm showing the management of tubulointerstitial nephritis. So complications, delay in diagnosis and treatment worsens the condition. Renal insufficiency is the common manifestation that ultimately progresses to end-stage renal disease. So the patient may ultimately require renal replacement therapy. So differential diagnosis, acute tubular necrosis, arterioembolism, glomerulonephritis, obstructive uropathy, vascular injury. So in conclusion, acute tubular nephritis is a frequent cause of acute kidney injury. Drug-induced tubulointerstitial nephritis is the commonest etiology. So antimicrobials and NSAIDs being the most frequently offending agents. So pathogenesis is based on cell-mediated immune response in most cases, and removal of the offending drug is the mainstay of treatment. So thank you for listening. I couldn't go through the whole slide. Thank you.
Thank you so much, Dr. Zach, for extensive presentation. Okay, we'll take comments from the participants first. Okay, so there are a lot of, let's keep the thanks coming. There are a lot of comments on the chat already. Thanks for that thought-provoking presentation. So Dr. Ifeoma is saying, thank you so much for the presentation. Dr. Lali is saying, good morning, thank you for the presentation. Dr. Zakia, please take note, what's the difference between NSAID-induced TIN and analgesic nephropathy? So is there any difference between HIV-induced TIN and HIVAN? Then what's the commonest histologic finding seen in patients with HIV-associated disease, HIV-associated kidney disease? And then 24-hour urine protein estimation and or urine albumin-creatinine ratio is very important, considering the finding of proteinuria of 3+ on dipstick. Thank you. Okay, I think you should take this first. It's quite a lot before we move on.
Okay, thank you very much. So in HIV-associated nephropathy, the common finding is usually that of, they usually have the collapsing variant of focal segmental glomerulosclerosis. So in such patients, they have proliferation or enlargement of the podocytes, and there is usually increase in vacuolation and wrinkling of the podocytes. They also have collapse of the capillary walls, even though they could have microcystic dilatation and tubular dilatation in addition. But the primary feature seen on histology is the collapsing variant of focal segmental glomerulosclerosis, which is manifested as hyperplastic and enlarged podocytes.
All right. Okay, later maybe the nephrologist will add more to that. Is there any difference between HIV and TIN, HIV-induced TIN and HIVAN? Hello, Chief. Hello, Chief, can you hear me? Am I being heard?
Yes, doctor, but it seems her network is not too good. Can you allow the people raising hand to speak?
Okay. So let me just take the chats that are not questions.
Can't hear you, Fatima.
Okay, it's tenofovir that's network. Okay, it's tenofovir that's not nephrotoxic. Okay. Then Dr. Loriko, what are the possible differentials of normal size kidney and ultrasound scan? Dr. Muhammad is saying, thank you for the presentation. Actually, it's tenofovir that is substituted for abacavir, not lamivudine. And lamivudine is reduced to 30 to 50 milligram daily once the GFR is less than 30. Others are saying, thank you for the presentation. Okay, Dr. Okute is saying, thank you for the presentation. The question is quite tricky, especially if you don't have the privilege to see the other questions. Maybe a problem with recall. Either most likely be the diagnosis in this case, even though clinical scenario might not really give it out completely. later stages of HIVAN, they could spill that much protein urine, and the renal biopsy could also be the findings in HIVAN later stages. UPCR is also an important investigation, and tenofovir is the one substituted with abacavir, not lamivudine. The others are saying thank you for the presentation. Okay, so let's take the hands are up. Okay, Dr. Florence, and then Dr. Ibinabo. Okay, Dr. Florence, you have the floor.
Okay, so good morning, everyone. Okay, so going through this question, I think there was a problem with, Dr. Sakia did an extensive job here. So I think there was a problem with the recall, if I'm being asked. So I was trying to find out different things that can cause tubulointerstitial nephritis, of which I saw NSAID, penicillins, and also I saw tenofovir, isoproxyl fumarate. It can also cause tubulointerstitial nephritis. So going to and then also sulfur-containing drugs. So going to HIV-associated nephropathy, in Medscape, when I actually went through Medscape, they said it can actually present with tubulointerstitial scarring, atrophy, and marked dilatation of the tubules. That they said they present with microcystic dilatation at the tubules. So from my own angle, I'm thinking this patient actually has HIVAN, and then probably what caused that tubulointerstitial nephritis is from the drugs, which is the tenofovir, isoproxyl fumarate. So in treating these patients, I think the tenofovir isoproxyl fumarate can be substituted with alafenamide. Alafenamide is not nephrotoxic or abacavir, as she said. Then, for HIVAN, the kidneys are either normal in size or they are enlarged. So for them to bring the size of the kidney, I think somehow there was somewhere up there where they put maybe RFID or something. To me, I'll prefer to work with HIV-associated nephropathy, and then the tubulointerstitial nephritis probably must have been caused by the drug the patient was on. So that's my own thinking. Then in managing the HIVAN, most times in managing, they'll say give highly active antiretroviral therapy, because most times it's reversible when you give the drug. So I would think maybe we would start with HIVAN for this patient, and then give maybe ACI or ARB that will help with the proteinuria. Then some studies actually say that cyclosporine can actually help in treating the proteinuria. Then every other thing can follow with it. So it's between HIVAN or NSAID, but I think I'll go more with HIVAN, but there's a problem with the recall of this question. Thank you so much.
Thank you so much, Dr. Florence. Dr. Amakri. Good
morning, everyone. Thank you so much, Doctor, for your presentation. Thank you, Dr. Florence, for your addition, and Dr. Puti. They've said basically what I wanted to say. Then what I want to say basically, for the tubulointerstitial nephritis, they didn't give us any pointer apart from the NSAID. Maybe they would have said patient had rash and maybe fever. Then also, she kept talking about acute. That biopsy is not depicting, it's not giving us a picture of an acute tubulointerstitial nephritis, because the acute stage, we usually see infiltration of cells, the lymphocytes and all that. Although NSAID can cause the chronic form, but I also think of HIVAN for these patients, and also maybe an acute tubular necrosis for the patient rather than the tubulointerstitial nephritis. Thank you.
Thank you so much, Dr. Lawrence. Hello, Dr. Ade. Okay, if you can't hear me. Okay, Dr. Yusuf.
Thank you, Dr. Kele. Hello, am I audible?
Good morning, all. Thanks for the opportunity to speak also. Thank you,
Okay.
Doctor, that presented. It was a lucid presentation. Hello, are you hearing me?
If we can hear you now, go ahead.
Okay. I may be a little bit different from the presenter about the choice of the choice of the diagnosis, because they categorically stated that this patient has 3+ of protein, but we have not done albumin creatinine ratio to actually confirm whether it's a nephrotic range proteinuria. NSAID-induced tubular interstitial nephritis, we can cause nephrotic syndrome, but it's not a very common feature to cause nephrotic syndrome. Secondly, they categorically stated that the renal size was normal, which not a typical feature you can see in NSAID-induced tubular interstitial nephritis. I would have rather chosen a differential like a HIVAN as the first, as Dr. Amachiri said. Then secondly, we call it lupus nephritis, because why will a young lady of that age be taking NSAID recurrently? So something must have been the cause for her to be taking the NSAID. So I will have thought maybe the patient has autoimmune condition like lupus nephritis that is warranting her to be taking NSAID to be, as indicated in the, the history. So the picture that they painted as renal biopsy is not a classical one that you can see in HIVAN, but with that cystic dilatation that they mentioned, and for somebody to think that
I can't hear again. Is it me?
I can't hear him too. Okay, I think he's no longer there. Okay, Dr. Yusuf. Hello, Dr. Yusuf. I think you can go ahead. I think we lost him.
Hello, yeah. Good morning, everyone. Please, am I audible?
I can hear you.
Yeah, thank you very much. Please, just a few comments. I think I also want to go with the HIVAN, the HIV-associated nephropathy, and also because of that last comment too, because I wonder why they would have brought the latest drug combination in HIV. Then to respond to Dr. Kalamama's comment, if one is suspecting nephropathy, of course, we cannot use the usual DTL or TLD. The tenofovir cannot be, that's the tenofovir desoproxil fumarate cannot be substituted for alafenamide in this patient. And why I think that is that even for tenofovir alafenamide too, it's also contraindicated once the EGFR is less than 15 mL per kg per meter square, which in this patient, if we should calculate the EGFR, it is likely to be less than that. So it's better to still substitute the tenofovir desoproxil fumarate to abacavir. For alafenamide too, once EGFR is less than 15, you can't use it as well. That's my comment. Thank you.
Wow, thank you so much. Okay, lastly, Dr. Anthony.
Okay.
Dr. Anthony.
Okay. Sorry. Good evening. Good morning, facilitators and colleagues too. Please, and first I want to thank the last speaker. She did a wonderful job. She tried very well to be extensive in her work. But I just wanted to make a little contribution. I'm not entirely different from the others. But when I'm looking at the question, the STEM question itself, the first thing they talked about was a chronic use of NSAIDs. It was at the end they now mentioned They talked about the antiretroviral drugs that one can use. But all these things, I have any diagnosis one makes, none is going to be in the real sense perfect. We're looking for a diagnosis that can capture everything about the patient. In my own opinion, I would say that because there are two things one was going through my mind was to say, maybe I can marry everything and say a chronic interstitial nephritis secondary to HIVAN with nephrotic range proteinuria. That's probably what I would think about. A tubular interstitial nephritis, possibly a chronic interstitial nephritis from secondary to HIVAN with nephrotic range proteinuria. And then probably all they have said about the antiretroviral and the others, I think I also agree, but that's a contribution I want to make. But that is still subject to what our teachers will say. Thank you.
Thank you so much, everyone, for the beautiful comments. Okay, so Ma, I think we'll take comments from our teachers now. Ma Christabel.
Okay, thank you, Tekele. I must appreciate everyone commenting. So wonderful, really, really amazing. Chief Amigos, Chief Chitu, any comments without time?
Okay,
Yes,
so
sir.
quickly before Chief Chitu says something. Yes, thank you for the presentation. I want to start by saying that the question is actually a little bit difficult, okay? So, but there are some key things you're supposed to take from the initial question. 1, proteinuria of 3 pluses. 2, the range renal profile. 3, the normal sized kidneys. And then 4, a young lady that is within the reproductive age group. Okay, so I think these are the key things. And then the fact that she's been on NSAIDs and for joint pains. So marrying all this together, I think one should, the first differential here actually, because of the 3 pluses of proteinuria, normal sized kidneys, and her young age, then might be, one can think of HIVAN, okay? However, the little issue with HIVAN is most oftentimes they don't present with pedal edema, okay? Because it's usually a salt-losing nephropathy, okay? So, but that sometimes they can still have, depending on other things. Now, the second is SLE, okay? Especially the membranous type, the membranous class of SLE. It's typically the one that presents with the nephrotic range proteinuria, even though many times they might have normal renal function. Okay, so another one is, of course, analgesic nephropathy. Okay, so because of chronic NSAID use, all right? Now, remember that it's possible they didn't bring up the issue of the questions about a change of antiretroviral and stuff like that at that point. So you might not have known that. But yes, HIVAN is actually very possible because of the proteinuria, normal size kidney, and her age. Okay. So, and those are part of the things that you should ask when the other questions that you ask when you want to take a history about. You can even ask directly if she's ever been diagnosed with retroviral disease, or even then find out about other sexual habits and all that. Okay, so the presenter didn't do badly actually, because the question was not straightforward first. And one thing I can assure you is that most often times what they are interested in is not your diagnosis, it's your thought process. Okay, did you pick up the key things that they wanted you to pick up? Did you pick up the fact that her age, her sex, the presentation? Did you pick up the normal sized kidneys and all that? Okay, so I think that's the most important thing I wanted to contribute. Most of the other things that have been said about the change, that it is not the lamivudine but the tenofovir. Yes, please. You have to note that the presenter. Okay, so and I don't know how you calculated the last speaker. or is it the speaker before the last, that the EGFR will be less than 15. I actually doubt it. Creatinine is 200 and something, and she's 35. It might still be greater than 15. But the truth is, as much as possible, if there is significant renal impairment, just forget about the other tenofovir. Just go straight for Abacavir. Even though that one needs to be adjusted for renal function, as the presenter had mentioned. Okay, so I think these are my contributions. Thank you.
Oh, thank you, sir. Chief Chitu, sir.
Good morning,
Good morning,
Dr.
sir.
Christabel. Well done. I think Dr. Remigus has already dealt with everything that needs to be dealt with. Please, it's a very important to bring a histological slide for general medicine class. If you're not in the specialty, you may not be so, into looking at such slides. Okay, but yes, the slide just paint on what they showed. They barely showed any glums, so it's difficult to say any other thing. But if you look at just the slide alone, you'll say it's a chronic tubular interstitial nephritis. But with information given about the patient, including the urinalysis and all of that, then you can say with some level of surety that this may be something that also affects the glomerulus, and you would want to swing towards HIVAN because of the patient's age and gender. Okay, so that's why you want to swing towards that. But Dr. Remigus had already read on my thoughts. Then I don't know, I think the speaker mentioned giving steroids to somebody with chronic TIN. When it's chronic TIN, steroids, the steroids are not going to do anything again. There's no point. Just treat the underlying condition that's causing the problem and hope that you can preserve or whatever renal function is left and slow down progression. That's the only thing you can do then. There's no magic steroids will do in a chronic TIN. You only do that in an acute scenario. And the picture they gave you was that of a chronic TIN, not an acute one. So, well done, everyone.
Oh, thank you, sir. Thank you. Dr. Ekele, over to you.
Okay, Ma. Thank you so much, Ma. Thank you so much, our teachers. Okay, so we'll take the second question. Chief, you have 10 minutes. Dr. Titulope will take in the second question. Okay, Chief, go ahead. You have 10 minutes. Hello, can I be heard?
Yes, you can.
He's muted. He's muted.
Dr. Titulope, please unmute yourself. And you can go on.
Good morning. Can you hear me now, please?
I can hear you. Go ahead.
Oh, thank you. Thank you. Good morning, the consultants and our trainers and the residents on the platform. I'm Dr. Gushola. I'll be taking the second question of November 2023 MPMC and General Medicine question. The question is, a 45-year-old ICU nurse developed a fever, dry cough, breathlessness, and sore throat of 5-day duration. She is known to have COPD. The blood pressure was 148.98 millimeter of mercury. Temperature was 39.6 degrees Celsius. Saturation was 74%. Chest X-ray was said to be normal. Laboratory results showed leukopenia, thrombocytopenia, and elevated fibrin degradation products. The questions are, list 3 differential diagnosis. What is the most important investigation, and how will you manage this patient? I will do a brief summary so that it can be clearer. The age of the patient was 45 years. Occupation is an ICU nurse, and net care practitioner. The present complaints were 5 days history of fever, dry cough, breathlessness, and sore throat. And we should know that the patient had the background COPD. The vital signs were elevated blood pressure 148, 98. The temperature, she was febrile, and she was the patient desaturated. The available investigation showed that the chest X-ray was normal, and the laboratory investigation showed leukopenia, thrombocytopenia, and elevated fibrin degradation products. The three differential diagnoses that I'll be entertaining, considering the presentation and consider the differential are COVID-19 pneumonia, then community acquired pneumonia or nosocomial pneumonia, and pulmonary embolism. Those are the three top differential that I'm thinking of. However, is a recall. Some information were missing, or at least with the little I could get, I will be thinking more of COVID-19 pneumonia. Then what's the most important investigation that I will request for? And the most important investigation is COVID-19 screening, which can test for either COVID-19 antigen or antibody. And other investigation that may also be necessary, at least to rule out the differentials, also to confirm the diagnosis are the chest CT scan. If it's COVID-19, it may be normal, or it can show multilobar ground glass opacity. And blood culture can also show evidence of sepsis. ECG can show, if it's pulmonary embolism, ECG can help us show, it can show the typical S1Q383, and there can also be tachycardia. Where they didn't show it was not documented the pulse rate, that we don't know whether the patient was tachycardic or not. And echo can also show features of pulmonary embolism. And we need to do creatinine, the baseline. COVID-19 was designated severe acute respiratory coronary syndrome. The virus that caused it was designated a severe acute respiratory coronavirus 2. That's SARS-CoV-2, and the illness it caused was coronavirus 2019. It was first reported at the end of 2019. And it was late because of the affectation of many continents, or later proclaimed the global pandemic in 2020. The spectrum of COVID-19 in adult ranges from asymptomatic infection. Some patients may not be symptomatic, especially many patients, even health workers. And they can also range from asymptomatic to mild respiratory tract infection to severe pneumonia with acute respiratory distress and multi-organ dysfunction. The patient in question appears to have a severe complication, and our understanding of the spectrum of disease as well as optimal management strategy continue to evolve because it was discovered they've discovered SARS-CoV before, but this COVID-19 was just came into existence in 2019. That there are still the knowledge about it is still evolving. That vis-a-vis the management. The possibility of COVID-19 should be considered in anyone with new onset fever and no respiratory symptoms. And the patients in question had the fever, breathlessness, cough, but they didn't say much about the type of cough. It was not properly characterized, right, because of the recall. There are no specific clinical features that can reliably distinguish COVID-19 from other viral respiratory infections. There can also be a form of atypical pneumonia. But basically, these are some of the symptoms that may be seen in symptomatic patients with COVID-19. And they may present with rhinorrhea and nasal congestion. About 75% were reported to present with such. Headache can be 70 to 75%. The reference is at the tail end of the presentation. They can also present with headache, 70 to 75%. Sore throats. This patient present with sore throats, apart from the normal respiratory tract infection. They can also present with cough, chills and rigor, fever, myalgias, confusion, anemia, chest pain, nausea and vomiting, fatigue, dyspnea. And this pathophysiology of COVID-19 is caused by the virus called SARS-CoV-2 virus, and is usually inherited from the aerosols. And infection is when patient is exposed to the virus, there will be infection of the transbronchial and alveolar epithelial cells, especially type 1, and this will lead to severe lung damages and other organs impairment. Unfortunately, it can also lead to activation of immune cells, that is the macrophages, lymphocytes, and dendritic cells. And the affectation of the lung can also lead to increase in secretion of the chemokines and cytokines, which subsequently leads to inflammation of the lungs or the other organs, and there can be decreased blood pressure because of the elicited the affectation of the immune system. Then acute respiratory distress syndrome and subsequent multi-organ failure and death that we see. The diagnostic test, a viral test is necessary to make the diagnosis of this infection, and it can either be nucleic acid amplification test, most commonly done with reverse transcriptase PCR-RC, and that's what many people do, and it can also be done by antigen test. Basically, for this patient, we request for COVID-19 at least to confirm the diagnosis. And defining disease severity, the severity of COVID-19 can be defined by the need for oxygenation or ventilatory support, especially when the patient is really breathless, and hypoxemia when the saturation is less than 94% in room A, and the patient in question, the saturation was like 74, which show that the patient present with had a severe form of COVID-19. How will you manage this patient? Well, it depends on the presentation, but for these patients, we know the presentation coupled with the background SOP that the patient had. Because the patient will need to be stabilized with oxygen therapy, the fluid and electrolyte balance, and we also need to give antipyretic. And we need to give, if the patient is not responding to the Abuvac, then we need to admit to ICU, where patient can be put on intubated and placed on mechanical ventilation. Then, if COVID is confirmed from the test, we might need to do the normal the COVID regimen. But I will take it properly now. The treatment it can be supportive therapy, which is by the use of by giving oxygen. But we should remember that this patient had the background COPD, that the saturation, we should aim at saturation of 88 to 92%, because the patient will still need hypoxia to at least to drive the respiration. And antipyretic, like I said, if there is no contraindication, can be given for fever, or PCM2 can also be used. And because of the high level of FDP, we showed that probably they may be prone to having thromboembolism. The patient will also benefit from anticoagulants, and the patient has to be admitted into isolation center with ICU capacity. Patient is given high flow supplemental oxygen or non-invasive ventilation. They may benefit with low dose dexamethasone, that's steroid, that's 6 milligrams, is usually recommended. But for those who are within 24 to 48 hours of admission to an ICU or receipt of ICU care, and within 72 and within 96 hours of hospitalization, adjunctive Janus kinase inhibitor, which is used to treat rheumatoid arthritis.
Please, you have 1 minute more.
Oh, thank you. I also suggested. And for patients that are immunocompromised, remdesivir is also recommended as an additional antiviral therapy. And other adjunctive therapy zinc have also been used, and the vitamin D supplementation is also recommended, at least to meet the recommended intake or treat deficiency. Ivermectin is also has also been used, especially for patients receiving a glucocorticoid, in order to prevent spondyloitis reactivation. These are the references that at least I use. Thank you so much. I'm sorry for taking more than the required 10 minutes. Thank you.
Thank you so much, Dr. Gunsola. You're on time. Thank you so much for the lucid presentation. Okay,
thank you,
so we'll take comments and questions from the participant first. And let's keep the thanks coming on the group. Okay, so Dr. Afolabi Michael says, acute exacerbation of COPD precipitated by chest infection is an important differential. Okay, exacerbation of COPD, I agree. Chest X-ray is Dr. Muhammad says chest X-ray is important. I think chest X-ray has already been done. That's why he mentioned CT. So well done. Dr. Wiki says well done. Okay, they've already mentioned this. Exacerbation of COPD is a differential. So please, what are there other risk factors for COVID in this patient, apart from being a nurse in ICU?
Thank you.
Just ask them.
Chief, you want to react?
Yes, I'm listening, please.
Okay. So
Hello.
are there other risk factors?
Well, thank you so much. Where the major risk factor is being a nurse in ICU, which and coupled with the fact that we still have the little surge of COVID-19. That means the patient may be exposed because of the work. However, the recall wasn't complete. I don't know whether there are other risk factors that were properly stated.
Okay.
And
Okay, thank you. So
the
Dr.
known,
Oladeko,
I don't know.
okay.
Hello, I can hear you. Please.
Okay, so Dr. Oladeko says, thank you for the presentation. Multidisciplinary approach is very important in this index patients. The pulmonologist, the intensivist, the medical microbiologist,
Yes.
the pharmacist. Yes, thank you, Dr. Oladeko. Very important. Even the
Even
infectious disease
hematologist.
specialist, hematologist, yeah. Yeah. Dr. Adibipe says, thank you for the lucid presentation. Dr. Okarafo says, thank you to the presenters. Dr. Blessing Azukoyamade said, thank you. Dr. Eviti, thank you so much. Dr. Charles Okore is asking, COPD risk factor for COVID. Okay, I think that's the last.
Oh, thank you. Where I'm not sure. I'm not sure. I didn't come across that.
All right, thank you so much. Okay, so Dr. Mamadou, please go ahead. There are some hands, electronic hands up. Dr. Mamadou, go ahead, please. Okay, I can't see him again.
Good morning, our facilitators and colleagues. Sorry. Yes, please. I am just trying to look at it from the aspect of maybe COVID and COPD. You know, typically for us, the GOLD, actually, we follow the GOLD guideline for even their management. And from what this patient has presented with, symptoms of mild COVID will include these constitutional symptoms with fever greater than 37.5, increased shortness of breath, dry cough, fatigue, even diarrhea. And what you normally would do is to assay for that SARS-CoV-2 PCR, as you said, typically chest X-ray, CT, SpO2. On full blood count, you will see lymphopenia and also thrombocytopenia. You could also do CRP and D-dimer. These are classified for us under COPD as mild COVID-19 with background COPD. And in terms of treatments there, typically for this particular patient, because an exacerbative episode typically will have worsening cough and shortness of breath. So what we normally would do for this COPD patient is to ensure that we'll continue the usual COPD maintenance drug that patient is based on the GOLD standard of the GOLD class group that the patient is. Then we will now do protective strategies. These protective strategies are actually different in terms of getting all these wearing face masks, maintain physical distance, follow basic infection control measures, then if possible, vaccinate. Then we'll look at the possibility of the COPD exacerbation. We'll treat the exacerbation itself and treat using our exacerbating. We can use the bronchodilators to actually help, even give the steroids for this particular patient, treat this exacerbated episode. Then there's also a room for, because of the COVID-19 risk of thromboembolism, there's a place for low intensity exercise and possible therapeutic trials or the COVID drugs that you now treat alongside. It's being managed as a spectrum. If that doesn't suffice, the shortness of breath can worsen, the hypoxia can become even much more. Then an arterial blood gas now differentiates it, puts it with typically an ARODS, typically towards an ARODS picture, where you look at the PF ratio. If it's less than 300, it's not gotten to ARDS. As at this particular time, you can now use some of all those systemic steroid, remdesivir, anticoagulation, controlled oxygen, still maintaining the usual maintenance dose of COPD. If it gets into ARDS, then the saturation is very important. LDH you must measure, interleukin 6 you must measure, D-dimer, ferritin, troponin, BMP, you must measure them. And this is an indication for NIV for these patients. And you can put in the prone position, anticoagulation, and even the treatment of the drug till they now have a convalescent COVID, meaning that has resolved. They just, because we have just the fatigue, shortness of breath, and cough. As at this time, it's a little bit more stable then you can now begin to do some of our other tests to reassess. Pulmonary function test, you do a chest CT to even look at what has happened, why you still continue these drugs, and possibly home exercise and pulmonary rehabilitation. But at that ARDS stage, we are not thinking of COPD maintenance dose again. If the patient is in ARDS, you give as needed oxygen, because the patient will die if you are thinking of just maintaining that.
Am I the only one not here?
I'm also not hearing him again.
I was thinking the same thing, because network has been so terrible.
I think the network has been bad since morning.
Network has been bad for days
Okay.
now. There's diesel protesting. So, Doctor, while wait for Dr. Mahmoud to round up, Dr. Florence, please. It's past 8.
Responding.
Hello, Dr. Florence. Am I the only one not hearing? Ma, please, can you hear her?
No, I can't hear anyone.
Okay, are you hearing me now? Hello,
Yes.
Ikele? Okay, I was
hear you
hearing before. Okay, just an add-on. The presenter did a beautiful job. Just an add-on. Okay, you should have at the back of his mind that this patient has COPD. For the aspect of oxygen therapy, we should start with Venturimax for this patient. Thereafter, if that doesn't suffice, then we can now go to the non-invasive ventilation. If that doesn't suffice, then we can now go to the invasive ventilation. So it should be at the back of his mind that this patient has a background COPD. So we'll give oxygen via Venturimax. So that's just the add-on I have to say. Thank you so much.
Oh, thank you. Okay, ma. Okay, I think Dr. Mahmoud has added. So
Okay.
don't forget. Yeah, okay, ma, I think I'm good for teachers now.
Dr. Fatima. Dr. Fatima Zanis. Dr.
Yes.
Fatima, please go ahead.
Yes, ma. I want to make comments regarding the exam. I sat for this exam, so I don't know if it will be